Okay, we're going to get started. Thank you very much for joining us this afternoon. One moment while I tee up my presentation. Okay, great. Well, again, thank you so much for joining us today in this very busy and stressful time. So hopefully this presentation will be helpful to you. My name is Jennifer Gross. I'm a senior healthcare specialist at PointRight. And co-presenting with me today is my colleague, Maria Arellano, who is also a senior healthcare specialist. And we are here to try to make some sense of all of the recent updates and policy changes that have been unleashed on the healthcare space and skilled nursing facilities in particular in response to COVID-19. So before we begin, we have a little disclaimer. Bring that up. So, as you know, things have been changing very rapidly, multiple times a day even. So this presentation is as up to date as we could possibly make it. But since the situation is continuing to evolve and it's very fluid, CMS has been issuing clarifications as they go, as situations arise. So please keep an eye out for changes. So you can look for any updates to policies or any changes to the waivers on the CMS waiver website specifically. And of course, they have a centralized location for COVID-19 materials as well. So keep an eye peeled for that, but we'll do our best to make some sense of what's happened up to date. So, of course, this COVID-19 pandemic has really long past reached the crisis situation in the healthcare space, and CMS has been responding very aggressively since the national state of emergency was declared on March 13th. Once the national emergency was declared, CMS had the ability to begin to issue many waivers to existing policy. Now, as a blanket time frame, these waivers are intended to be effective for 60 days from the date of the national emergency or until the state of emergency is lifted. However, the CMS may very well extend this time period for as long as is necessary until the situation is under control. So there is technically an expiration time to these waivers, but expect that to change. So we on the clinical resource team here at PointRight have been spending the last few weeks digesting CMS transmittals and memos and the underlying policies that are being waived to try to make sense of what's going on just along with the rest of you. And for the purposes of this presentation, Maria and I are grouping these waivers up to date into 4 broad categories that seem to fit the themes of the waivers in common. So we'll be talking about access to care, specifically for Medicare beneficiaries, but in general, any skilled nursing facility, resident or patient. Residents' rights, of course, there are a few waivers that are related to that. The assessment and data submission policies, there are some waivers and also some new information. And administrative, general issues related to physical structure and reimbursement. And of course, there is the focus on infection control from surveyors. So we'll be talking about that as well. Before we begin talking about the waivers, so just a little bit of a definition. Because CMS has been issuing waivers both as blanket waivers and individual waivers. So we just wanted to make this distinction before we get started. So for the majority of circumstances that should fit most skilled nursing facilities in the country, CMS has issued blanket waivers. And what that means is the waivers are effective, actually retroactive to March 1st. And there is no need for an individual provider or an individual state to apply for those waivers. Now, some of the 1135 waivers, as related to the regulations that are being waived, some of them have to be applied for. So they're not included in the blanket waiver. The states have to apply for them individually. Now, most states have already applied for these blanket waivers, and there's a list of those states that have active waivers on that CMS waiver site that was on the prior screen. So check that out, look for your state, and in particular, click on the link of your state and look at their application, because not every state applied for all of the available waivers. So make sure that that the state that you're operating in, make sure you're aware of which regulations are being waived and which are still in effect. Now, CMS said, there was one of their many calls yesterday, they said that they are fully aware that they haven't issued waivers to fit every single circumstance, so they are looking for feedback for circumstances that they hadn't considered yet. So expect the situation to evolve. So with that being said, I'm going to hand it off to my colleague, Maria Arellano. I neglected to mention at the beginning of the call that these slides are in a handout that's attached to the GoToWebinar toolbar. So feel free to click on that link to download that handout. So here is Maria.
Great. Thanks, Jen. The first broad category that, as Jen mentioned, that we'll be discussing is access to care for Medicare beneficiaries. And so the first one is the 3-day prior hospitalization waiver. And that one provides that temporary emergency coverage for skilled services without the 3-day stay, right? And Again, this is temporary. It would be lovely if this was more of a permanent thing, but definitely temporary. And the whole intent behind this is really about preserving hospital beds for the greatest need, right? It's about freeing up that space for folks, and the capacity is such a big concern with this pandemic. And so, if you think about it, the different scenarios that are possible here, you might have somebody that's coming to you from the hospital and they've only been in the hospital 1 or 2 days. And so they're coming directly. So again, they still can go on they can still, if they meet the criteria, they can still be covered under Medicare in your facility, despite only being there 1 or 2 days. They could also come to you directly from the emergency department. So, somebody goes into the hospital and they deem that, this could be safely taken care of elsewhere, but not quite maybe home. You could bring them directly to your facility from there, and again, still access their benefits. They could come to you from the community. So maybe after they've had a call with their physician and the doctor says, no, the emergency department isn't the right place for you. Let's see about getting you admitted to a skilled facility where you can get the care you need, since you do not need, acute level of care. And then also think about the patients or the residents that you have in your long-term side, parts of your units. And they may need, maybe they've come down with symptoms, respiratory illness, or other conditions that would warrant skilled level of care. Again, no need to have that 3-day hospitalization to qualify for the benefits. The second piece of this is one that I think is causing all of us a lot of confusion. And unfortunately, CMS has not done a great job here in terms of really clarifying this one yet. Others they have done addressed in FAQs, and so we're watching to see if we do get some more additional clarification here. And so the intent of this is to provide additional skilled nursing facility benefits for a Medicare beneficiary who at the time of this disaster had exhausted their skilled benefits in their current benefit period, and I highlighted this because I think this is an important component, and was in the process of establishing a new benefit period. Okay, so think about your resident or patient that maybe went home even, and they had their rehab and their skilled care, and they went home, and 25 days later end up with respiratory symptoms or whatever, and maybe they get checked out in the ER, but there's no admission there, and they recommend nursing facility care. Okay, they were in the process. They've maybe only been home 20, 25 days, right? And so they didn't get their 60-day wellness period, right? And so, but they still definitely have a skilled need. There's likely this person could be covered. There's a lot of confusion, as I mentioned, on this, and I think we're all, like I said, still very unsure of this one. But if you're going to use this, be very, very cautious and make sure you have clear clear guidelines on this, because it's not intended for those individuals like residents with a tube feeding, right? Everybody just says, can I just keep them on? Can we go another 100 days? And no, that they've been clear about that is not the intent there. So again, we're going to be watching to see if there's some additional clarification, but basically what the key thing here is in the process of establishing a new benefit period. Next slide, please. The next piece about access to care, the next set of waivers, have to do with telehealth, and this one's exciting. I think again, this would be another one I would hope would stay well after the emergency is declared over. But the opportunity to use telehealth in all, for all beneficiaries in all areas of the country for all settings. Okay, so ambulatory is using it, home health is using it, SNFs can now use it, where you have the ability to work with your provider, or I should say the resident has an opportunity to have a visit with their provider, and still get but without that provider having to come into the facility to do that. Again, trying to prevent the spread of infection here. And so with that, you can do a lot of creative things. And I think as we're all getting kind of used to this the new world we're living in currently, we're all getting a little bit better at Zoom meetings and GoToMeetings and having those video calls. And so it's very much like that. The piece that goes along with that is the waiver to physicians' visits in skilled facilities. And the only piece of this 483.30 is a change, the wording to allow them to remove the language of it has to be an in-person visit, right? So now that does open the door for those telehealth options. And then the third piece that also goes with this is the HIPAA component. And so they're currently waiving penalties for any HIPAA violations against a provider that really was attempting to serve their patient in a positive way. I mean, this was a good attempt, but somehow, there might have been an infraction or some kind of a breach of information. But especially using things like FaceTime and Skype, you're allowed to use those mechanisms. They're really, this is a crisis situation, so they're lowering, removing that barrier for you, so that you can use it, knowing that access to technology, you've got to scramble to get some of that, right? Whether that be iPads or tablets, or even desktops, and being able to access all of those things. They know that sometimes things are going to happen, in the background. Maybe if you're in an area where somebody walks by or something like that, and or a resident another resident is seen in the background, those things are going to happen. I mean, there's obviously some things we can do to prevent that, but again, they're removing those, the penalties that may occur if those should happen, which is a real positive thing, I think, for this. And we've got to really make this effective. Next slide, please. We wanted to make sure we had specifically around telehealth. There's a lot of information out there, a lot of great tools that CMS has provided. You've got a fact sheet that goes over some really good components of the requirements. There's a telehealth and telemedicine toolkit just specifically for nursing facilities, and then the link to the information about the HIPAA waivers and how best to protect all residents to the extent possible, but the recognizing that we're in a bit of a crisis here. So I wanted to definitely provide you with those if any of you are looking to, or maybe you're already in process using telehealth and telemedicine. So these are, like I said, great resources. So next slide, please. And a couple of care considerations. We wanted to make sure we brought out some of these things to think about as you're exploring, using, and accessing some of these waivers. When you look at the 3-day stay and even the spell of illness, you still have to make sure that the beneficiary meets all the requirements of the program, right? The skilled level of care, all of those things are still need to be in place. And as I mentioned earlier, you do not need to have the full 60 days. But again, it should not be used to extend a Medicare stay that's already in process, right? Work with your physicians and your other providers to determine, the appropriateness of telehealth. Perhaps not all residents are appropriate for that, or all situations, but work with them as a team and your medical director to make sure that you are clear about when and where and who it may be appropriate for. And let's think about the telehealth devices themselves. You got to make sure you're including your mobile devices if you bring in new pieces that you hadn't had before. They're included in your infection control procedures, the cleaning of those devices, especially because they're shared, right, moved around. Clearly consider your environment. It can be very difficult, obviously, from a privacy standpoint that I just mentioned, but also making sure that just like when you do the interviews for a patient, the ones, the BIMS and the pain interviews and all of those, you want to make sure that it's quiet so that the resident can hear and be heard. I've recently had an experience with my mother doing a telehealth a visit, and a little bit hard of hearing and has some dementia, and so it can be very difficult. She really kind of struggled with the technology, so you've got to really make sure that you're very aware that you're and set up the environment that it's very conducive for a good positive visit. And then also consider the resident's experience with technology. If you've got somebody that's never done this before, I know my mother kept, even though she had experience with technology prior to her dementia, she kept pushing buttons, right? And it was, would disconnect things and move screens. And so they can be very frustrating for her. So again, using, making sure that you have that understanding and that somebody is with them and can, coach them along and not just, leave them be. That's very, very important piece of all of this. Next slide, please. The next grouping of waivers has to do with residents' rights. And obviously these are very, very important still, even throughout this crisis. But there were a couple of things that CMS did to make things easier for you, which was really wonderful. And obviously resident council. Think about that they have the right to form a group and be together and do things of their that they're interested in, right? However, we've got this social distancing requirement now and visitor restrictions, and so that makes it extremely difficult. So they waived that requirement just again so that you could have something to stand by and work with your residents on this. You want to make sure that if you come up with other options and other ways of doing these things, that they're still consistent with these current standards and policies that have been enforced by CMS. Along the same lines with residents, roommates, and groupings, right? We all want to make sure we have compatible roommates and things like that, and that it's all going to work. It can be very challenging, but however, we know again we're in a situation where that may not be possible all the time. If your facility has started seeing patients that are either suspected or confirmed COVID-19, you want to make sure they've given some guidance on how to organize and how to segregate and dedicate teams to those areas. And so in order to do that, you may need to move people around, and it may be against their will. They don't want to move, especially if you could think of, I always picture the resident that's been there for many, many years and has their room set up so nicely and has all of their personal items, right? And you're going to tell them they have to move. That's their room. Maybe it has a beautiful patio that they love so much. And it's just all those things that make it really, really difficult for them. And I'm sure very, very scary. But you have the ability to do that without the resident's permission. And because you need that flexibility to make sure that you're controlling the spread of infection, right? And this is a very difficult thing, I know, for many residents to understand. Next slide. So, a couple of key care considerations here. Obviously it's about being sensitive and reassuring the residents through really good communication, that this is a temporary measure, and this is not, going to remove their rights, right? They still have a right to say their mind, to speak their piece, but you really can work with them and say and do the best you can to help them understand and that this is really about the safety of residents and probably not so likely visitors anymore, but residents and staff, that keeping everybody healthy. Sometimes we do have to make those sacrifices, and reassuring them that as soon as it's safe, that that and you're able, you'll get them returned to their room of their choice. And if those room changes are necessary, again, ensuring that the residents' belongings are handled respectfully and safely and are fully accounted for. Maybe that's one of their fears and one of their reluctance, it's causing the reluctance to move is about, what about my things? And all that's all they have left of their possessions, right? Is what fits into a room. And so just being really sensitive to that and understanding that, and reassure them, like I said, that you're going to make sure that that's taken care of, and maybe they participate in some of that. And then consider alternate activities that preserve the social distancing. Get some ideas from residents and staff, or engage families via phone calls, maybe conference calls with families on how, what things that you might be able to do, or get some ideas. And there's many heads are better than one, right? And trying to come up with these creative ideas. I'm not sure. One of my favorite things I saw on social media recently was a facility. It looks like on one unit down a long hall, many of the residents were sitting in their doorways, right? They all had their masks on and they're in their doorways, but they wanted to be a part of the world, right? What's going on out here? And the staff were in the hallway doing the electric slide. And I just thought that was extremely creative. They were keeping their distance. They were doing what they needed to do, but yet it was very, very, very sweet and entertaining for the residents. And you could tell, they just really, really loved it. So again, thinking creatively might take a whole village. So next slide.
Yeah, and Maria, I mean, keeping spirits up is really key during this whole situation, for the residents and the staff, and also to reassure families that their loved ones are, that are being respected and cared for, which we know you're doing, but it can be hard under stressful situations to remember that sometimes. So Maria got to talk about some fun stuff, depending on what you consider fun. I've got the topic of assessment and data submission. So this is kind of my my calling card. So first of all, we've been waiting for this update to the Library of Available IC and Approved ICD-10 codes. Because CMS was planning to release the code that is specifically for COVID-19, not just any coronavirus, but COVID-19 infection. It was planned to be released with the next release of new codes October 1st, which is when they normally update the ICD-10 code library. This and the rest of that batch of codes having to do with vaping-related injuries and things like that, but specifically COVID-19, were pushed up to April 1st because of this crisis situation. So you now have the ability, effective April 1st, to actually capture an ICD-10 code specifically for a diagnosed COVID-19 infection. And that code is U07.1. Now, remember that this is just like any other diagnosis. You can only code this diagnosis if it's a confirmed diagnosis, documented by the physician. It has to be diagnosed by the clinician with supporting laboratory results indicating that either there is a confirmed lab result, or given the inability of unavailability of testing in many areas, that there is a definitive diagnosis of COVID-19 infection. And the CDC at the bottom of the page here has released official guidelines for coding COVID-19. So I highly recommend you download that because it's pretty clear on when you can code that diagnosis. Now, how does COVID-19 interact with PDPM? So COVID-19 will map to the pulmonary clinical category if it is the primary diagnosis. So what this means is that in the PT and OT categories, this will map to the medical management clinical category. And for speech-language pathology, it falls into non-neurologic. Now, currently, this diagnosis has no impact on nursing categories or non-therapy ancillaries. We'll see how that changes, if it changes. Hopefully it will, because this crisis is, incurring a lot of cost to the provider, which is what the non-therapy ancillaries are supposed to be accounting for. So that's all set. Remember that you can only capture this on a claim or an MDS assessment effective April 1st and later. Now, speaking of the MDS, another bit of relief that CMS has offered is the relaxation of the MDS submission regulation. So in 42 CFR, there's a subsection for the MDS submission time frame requirements, that you complete the MDS within a certain period of time after the ARD, and then you've got 2 weeks after the completion date to actually edit that assessment, make sure it's correct, and send it off to CMS. And then you can go ahead and submit your claim. And if that MDS is submitted outside that time frame, technically you're out of compliance. Well, this regulation has been relaxed, so that MDS submission time frame has been waived. So if you are a facility that really has to have all hands on deck with all of your clinical staff, including your MDS coordinators on the floor, caring, or if you have staff that are out ill, then it does give you a little space and a little breathing room. However, this is all we know, is that the submission time frame for MDSs has been waived for the time being. But there hasn't been any further guidance. I frankly think that CMS just hasn't had time to stop and think of what happens next after the state of emergency passes. So just keep that in mind, that all we know right now is that there is a little breathing room from the submission time frame. Now, another piece with data submission is the SNF QRP, the Quality Reporting Program, because the majority of SNF QRP measures are based on hospital claims. They've got their own waivers on their end that CMS has put into place. But MDS data from the SNF also plays into most of the SNF QRP measures as well. So there is an upcoming data submission deadline for Q4 of 2019 to get last year wrapped up, and then Q1 and Q2 of 2020. These 3 quarters, the data submission for SNF quality reporting measures will be optional, which is, kind of uncharted territory. And I should mention that these waivers that Maria and I are talking about right now have been put into place temporarily on under very localized situations. So SNFs in areas that are impacted by a hurricane or an earthquake or wildfire, the ability has always been there to issue these waivers for those affected SNFs to give them some relief while they're getting back on their feet. This is the first time that these waivers have ever been nationwide. So, we are really sailing off the map right now, and we're learning as we go. So anyway, back to the QRP. So, of course, that means, if data is not coming in or data is not completely coming in, then the QRP measures themselves will be affected by this waiver and potentially lack of data or inconsistent data. Now, we have no information yet on how long these measures are going to be impacted. If CMS plans to just freeze the measures for a period of time and then pick up again after data submission starts, and if there may be a blank period in these measures? We don't know yet. So again, further clarification is inevitably going to have to come once the dust settles. Now, as far as other assessments, there's the PASR, the Pre-Admission Screening and Resident Review, for residents who are admitted to a SNF with ID and DD diagnoses, intellectual disability, developmental disabilities. So what the waiver does is waiving the requirement that PASR has to be done on admission, which starts the ball rolling of getting to place the appropriate services for that new resident in your facility. Now, the PASR time frame has been extended. It's not been completely waived, of course, but that time frame has been extended to 30 days from admission, because regardless of any waivers, if you admit a new resident who has an ID or a DD condition, they need those services regardless, as to the extent that you can provide them. So the PASR has to be done eventually, but that time frame has been relaxed. And for payroll-based journals, PBJ staffing reporting, and I'm sure most providers are really struggling with capturing their staffing. You've probably got people covering multiple areas. You may have corporate people coming in and suiting up to get out on the floor. So you of course will need to make sure that you're capturing that information correctly. But the actual submission requirement for PBJ has been waived for quarterly submission of PBJ staffing data. The next deadline would have been May 15th. So we're in the middle of a PBJ quarter right now. So the upcoming deadline, which these PBJ deadlines are a hard stop. If you're one day late, you're non-compliant and you don't have your staffing reported for the following quarter. So this is really kind of a big deal for the PBJ waiver, that you don't have to submit this quarter. So again, uncharted waters. Now, another piece of assessment is, of course, when you're transitioning care from one setting to another, when you're bringing in a new resident to your facility or when you're transitioning them off to another facility. Now, CMS rightly anticipates that even no matter how much you want to be able to treat in place, there's going to come the situation where you may need to transition residents to another location for cohorting purposes, or for infection control purposes, or just the appropriateness of care. So the resident and transfer discharge, there's a whole slew of sub-regulations listed on the slide here that I won't read to you, but this enables a lot more flexibility in that assessment piece, and the information transfer and timing of notifications that happen when there's a transition of care to another setting, or going back to Maria's earlier piece on room changes, that notification piece has been relaxed. So a lot of pieces that we're used to having to check all the boxes and fill out all the appropriate sections, all of these areas have been relaxed. However, of course, you do still need to make sure that the appropriate information has been transferred to whoever needs that information. So, effectively, you're still going to be doing that information transfer if you're sending a resident to a different SNF for more appropriate level of care, for example, but you might not necessarily have to jump through quite as many regulatory hoops to do it. Now, the care planning piece, the requirements for baseline care plans and timeframes for that, and the comprehensive care plan that follows on to that have been relaxed. But this is specifically related for residents who are transferred or discharged related to COVID-19. So this is actually one regulation where CMS put some guardrails around this, because the expectation is that there is going to be baseline care planning and comprehensive care plan development going on in a facility for the residents who are not transfer of care, transition of care that's related to COVID-19. So at least there's one piece that CMS expects will continue to keep the ball rolling. But for this subset of residents, and that's why we have this highlighted in red, those care planning timeframe requirements have been waived for the time being. But of course, when you're receiving a new resident, just as in any other circumstance, you would want to make sure that the care plan that's been transferred over from the facility that the new resident is coming from has been reviewed and adjusted to be appropriate to their current setting. So the care considerations for these pieces are, basically just stay on top of the situation. These care transitions, and particularly some of these transfers have been very chaotic. It's not just sending one individual to a facility, to a different facility because of a change in their plan of care or more appropriate setting. This could potentially be transitioning an entire unit or an entire facility to another building because of the pandemic. Now, even though that you might feel like, oh, we just need to load everybody at a bus and send them over, and we'll follow with the EMR on a laptop afterwards. Just make it as easy as possible. But even with all the requirements relaxed, you do want to make sure that transition has been done as smoothly as possible. So the good old-fashioned warm handoff, if you can do a nurse-to-nurse communication on the phone, that would be as helpful as you can make it, just as if you're giving off report to the next shift, to make sure that they at least have an understanding of who it is they're taking in. You want to make sure you record this communication, though, because even if you don't have all the paperwork boxes checked off, you do need to at least have a record that this transition of care and the transfer of information did occur in whatever informal format you've made it. Of course, you're going to need to make sure that you transition all the key clinical data, the MARs and the TARs and the orders, and the current care plan over with the residents so that the new facility can pick up. Now, if you use PointRight and you have our radar solution, I just want to put a little tip in this. I don't want to spend a whole bunch of time talking about PointRight because not everybody on this call is one of our clients. But if you use a radar report, or for non-PointRight clients, any other module in your EHR system that identifies risk, radar can be really helpful to take the information from the most recent MDS for that resident, pull up the resident summary, and just give the highlights to the receiving providers. Are they at risk for pressure ulcers? Were they already at risk for mortality before transition? Or where are their ADL dependencies? Have they had worsening cognition? Do they have moderate pain daily that you want to make sure maintains that you address that? So that can be very helpful to at least provide the highlights of the key areas that need to be addressed in the care plan for the person who's taking in the resident to their facility. So we are actually going to pause for a second and toss it over to you folks. We have a poll, and this should be a pretty easy poll to answer. So I'm going to launch this in the webinar toolbar and leave this open for a minute. So that should be open right now. So select your answer. And the question is, has your facility taken advantage of the MDS submission timeframe waiver? So yes, we just don't have any bandwidth. We're flat out taking care of our residents right now and everybody's on deck. For some assessments, we're prioritizing them. We're getting the Medicare assessments done, but the quarterlies, they can wait till later. C is no, but we're thinking about it. We may opt for this if we need to. Or nope, we're good. We're on top of it. We have everything under control. So we are getting a lot of responses in. So I'm going to give this another moment. And I don't know, Maria, how long should I give? It's been a minute. We'll give it another
Yeah,
20 seconds or so.
I think just a few more seconds would be good.
Yeah. A minute and a half.
Yeah, drum roll here. That's what we need.
Yeah. And here we go. So share.
Wow.
So the poll results should be showing up in your toolbar now. There were 4% of the people on our call who are just, addressing their resident care right now, not worrying about their MDSs. Thank you for giving us your time today. But 70% say, no, we're staying on top of our MDS schedule and our submission. So, and if you can, that's a good strategy, because there's going to be cleanup. So, if you can stay current as much as possible, that's certainly what we recommend. Otherwise, there are people who are kind of splitting the difference and prioritizing assessments, and the remaining 15% are considering it. So that option does exist, and you can opt for it if you need to. All right, interesting information. Thank you. So I'm going to toss it back to Maria, and she is going to tackle some of the administrative pieces.
Awesome. All right, I'm not sure what screen is showing right now. Let's see, there we go. So next we'll talk about administrative pieces or components of the waivers. And the key one here, the one that I think everybody's talking about, is the accelerated advance payment. And the whole purpose here is to help with cash flow. CMS recognizes that this can be, catastrophic to a facility financially. And so the waiver really allows providers to submit a request to their MAC, hopefully in a simple form. I've not seen it, but they say it's a simple form so that you can obtain accelerated payments, or like an advance on your paycheck, for Medicare Part A and Part B services for up to 3 months of your historical billing. And the nice thing here is, CMS has already provided the information to the MACs about what you should get. You don't need to come up with your own historical data or do any of the legwork. So that was really, really positive. And so we've also provided you the link here if you've not heard of this or are still considering. There's some more information on it. But I think it's really important to know that this is a like I said, an advance on a paycheck, or an advance. So it's not a grant. It's not free money or anything like that, and it's not part of the payroll benefits or the bills that came out to help with keeping staff employed and that kind of thing for businesses. It's not part of that. This is purely for the Medicare A and B program, and so definitely there is a payback component here. And there's a time frame. So it must begin after the 120 days of receiving your payment, and it ends before the 210 days from that point. And so you can also work with your MAC on repayment terms. So, but you have some options. You can either do like an automatic recoupment via your claims process. And so as you submit claims, they just kind of take the credit. Okay, you've already been paid for that one in advance up until the point where all of the money is paid back. Or you can just determine that you want to have some kind of an agreement with the MAC and do some kind of payment schedule. And so you'd have to work with them, by paying them back by check or EFT. And so it's you have some options there. The interesting thing, I was really amazed. There was, I think, a memo came out last night, just kind of an update from CMS that said already providers have requested $34 billion in help. So this is all providers, not just SNFs. All providers across the healthcare continuum have already put in applications for that, totaling $34 billion. So I think that kind of tells you the serious nature of this and the impact that it has to facilities. Very, Very, very tough times right now financially. So again, if you need more information on that, there's the link provided for you. Next slide. Also, if you are a facility that is implementing or working on implementing a surge plan, so in your community, let's say you've been hit hard, and they're really looking at rearranging things. So they're asking skilled facilities or hospitals to implement their surge plans. And so, what does that mean? It means you might have to take on more patients than you have room for. And so this piece of the waiver allows for those non-skilled facility buildings to be temporarily certified and then available for you to use as skilled beds for isolation of COVID-19 positive residents, which might not be feasible in an existing skilled structure. So for whatever reason, again, you'd have to assess your community and your surroundings and your own facility and determine if you meet these criteria. One key thing to think about, if this is you, or if you're everybody start in their communities talking about it, you must get this first get approval from the state. Okay, even though this is a federal waiver, this is one that has to go through the state so that they can make sure that this location addresses safety and comfort for patients, and you get their sign off before anything occurs there. I mean, you think about it, this might be an old grocery store warehouse, or it might be you've seen convention centers being taken over. I've seen other like venue locations that are being taken over to facilitate this. In some of the warmer climates, you've even seen some of the hospitals using tents. They'll also have the ability to look at things with inside your facility. So if areas that are not normally used as residence rooms, so it might be the dining room or activity room or therapy room, if something that's not being used currently, then that they can accommodate beds and residents safely and effectively, that might also be something that could help with that, enhancing your surge capacity. Okay, next slide. And I'm sure, this has hit everyone for thrown them for a loop, I should say. And so, staffing may be an issue. And so CMS has waived the general components of the training and certification requirement of nurse aides. And so, right, we know that we cannot, maintain an employee who has not become certified within that 4-month time frame, right? So they've waived the general rule and clarified it, unless you show that that individual is competent to provide nursing and nursing related services. So they've waived the time frame, and they've given you some flexibility as to the training and the demonstrating of the competency. Okay, so it can be a little bit confusing. But let's say you had an individual or a group of individuals that went through a class but hadn't gone through finished it up yet, or not quite through the full certification process, and haven't been gone through the exam. Those individuals, and let's say the program has closed down, right? Because we've got to now isolate ourselves. So they're closing the training program. That individual, you could continue to employ that individual as long as you show that they are competent to perform certain tasks. Maybe it's not all of the tasks, right? The whole goal here is to help you obtain that temporary help you may need in this time of crisis. So whether they're temporary nurse aides, or eventually want to be long-term, but how you use them, you have some flexibility here. So if you think about it, looking at, okay, what have they gone through in their programs? What training has been provided for them? Perhaps they can do a partial job. So, meals and feeding assistance, everybody's in their rooms now, right? So you need a lot more eyes and a lot more hands, out in the units. And so perhaps that could be effective. Maybe that you have somebody, maybe they're still early in the training, and though you have folks that are the bed makers, and make sure that there's fresh towels and fresh water and all of those things, and breaking the tasks up into smaller groups so that the ones that do have their full certification and are well trained and competent to do all of the tasks, that they can maybe focus on other things. And so now's the time to get creative here. I know a couple of organizations. I know ACA has an 8-hour course that they're offering to folks as well as an interim training solution. But again, you still need to do the competency checklists and making sure that whatever you have them do, that they are competent in that area. So again, if it's a dedicated or a limited scope role, making sure that you've got to show the competency for that. All right, this is a national waiver, so you still must check with your state and the state occupational licensing and state regulatory requirements as well. So, all right, next slide. I think it's back to you, Jen.
Back to me. I get survey. Lucky me. So, of course, along with the changes to the regulations, surveyors will follow. So, of course, a part of this national emergency in this crisis is the suspension of normal survey activities. Your normal annual recertification surveys have been put on hold for the duration of this state of emergency. And now CMS did issue a comprehensive memo on March 23rd defining a 3-week time period where surveyors would focus specifically on infection control focused surveys. And we've seen focused surveys for dementia care and for MDS accuracy. This is the next piece. And now that 3-week time period is, just about up. So I certainly anticipate that these focus surveys are going to continue indefinitely, and then, frankly, this focus is going to be folded into the standard survey process, even though, it's building on the critical element pathways that have already been in place for infection control and prevention. So the focus surveys are triaging specific types of facilities. So if you were, looking at your watch at the very end of your survey window and expecting the surveyors to walk in for your annual recertification survey, unless you are on this list, you probably won't be seeing your surveyors for a little while. So these are facilities that, looking back over their 3 survey cycles, if they have a history of IJs, immediate jeopardies, for complaints or self-reported incidents. The targeted infection control surveys based on a survey history if the facility is in a key state that's been a hotspot for COVID infection, as well as survey history of prior non-compliance in the FTEGs for infection control. Now, this memo also included, attached at the end, the infection control checklist, which basically is the same as the critical element pathways that the surveyors are using now in this survey model, looking at the infection control piece. So if you haven't yet, you probably already have, but download this memo because that checklist is attached to it, and it really would behoove you to be familiar with that. Now, CMS has started talking about what they've found from the focus surveys they have done so far. And just as a reminder, the surveyors are bringing their own PPE, or they're supposed to be bringing their own PPE. So they are aware that everybody is strapped and doing what they can with what they have. But the deficiencies that have been cited, not necessarily for lack of PPE. If a facility can demonstrate that they're trying to get the PPE and there's a local shortage and they just have not been able to get the proper equipment, that's one thing. But the deficiencies that have been found so far have been in the actual practices of using the PPE and in hand washing technique. In particular, donning and doffing PPE is it's not just putting it on and taking it off. It's a very specific process to prevent, to keep the contaminated side in and not contaminate other surfaces or yourself or others while you're removing that gown or mask or pair of gloves. Now, surveyors are having staff demonstrate this. Hopefully they're not making them use up PPE just to do a demonstration, and they're doing observations during care. But key to being prepared for this survey, not just for these focus surveys, but just going forward, is making sure that your staff are able to do a return demonstration of proper technique of using their PPE and hand washing. Of course, that facilities have been historically cited for infection control since the dawn of time, but and hand washing has always been a big key part of that. Thanks to ACA, just as a sidebar, ACA has been doing a phenomenal job disseminating and organizing resources and advocating for the skilled nursing facilities. So big hat tip to AHCA. But these are the 3 resources that they have recommended for training materials. The donning and doffing PPE, these are documents you can download. It has color pictures of what you can see on the screen here for the proper technique and in written instructions. And there's also a video on YouTube that goes through both hand washing and PPE handling. So these are great resources. The CDC has all kinds of recommendations and things like that, but you really need to make sure that all of your staff are familiar with and able to demonstrate proper technique. And there's the OIG, the Office of the Inspector General. Guess what? Has updated their work plan. If you're used to the OIG just updating their work plan once a year, that is a thing of the past. The OIG now has the flexibility to update and create new revisions to their work plan as needs arise. So now they are specifically looking at COVID-19 from the perspective of potential fraud and misuse of funds, preparedness and response to infectious disease, and any other deviations from policies. So the OIG Office of Audit Services is on the game now, so you may potentially be hearing from OIG as well as your state agency surveyors. So the OIG work plan can be accessed at the link on the page, and there is a COVID-19 portal on the OIG website. So you may want to check that out as well, just to know what the other parts of the feds are looking at as far as infection control is concerned, and of course specifically the integrity of the Medicare and Medicaid programs and any potential fraud related to COVID-19 care. So we're getting into the home stretch here, but I do want to take a second for another polling question. So I'm going to take this poll and see if I can do it right this time. So this is a yes/no question, but we have a few options anyway. Has your facility completed CMS's infection control focus survey checklist? So far, we're at 100% yes. Very good. There's a yes. Yes, we're all totally in compliance. We're awesome. A yes, and we've used it to identify some gaps that we're working on. No, but we're going to do it right away. No, we have no plans to complete it. And what checklist? I hope you know. If you didn't know about this checklist, we just told you about it. So hopefully nobody's going to answer that. So we'll give it another 45 seconds or so for you to fill that out. So far, it looks like the first answer is in the lead. Everybody's doing a great job managing their infection control and in their facilities, so that's very good. Okay, we'll give it 15 more seconds. Okay, closing it out. And now I know that I need to share this so you can see it. So yeah, we're at 64% of the attendees are all covered. They are totally looking good as far as that infection control checklist is concerned. Another 26%, this is good. This means you've done the self-assessment and you know what you need to address, and you're doing the work to address it. And then the minority of people are either just about to complete it, or 2% have no plans to complete this checklist. They could very well have done their own assessment that is outside of what CMS has provided. All right.
That's great. That's terrific.
Yeah. So we're going to start to wrap it up. So Maria, tell me if you can't see the next slide.
There we go. Awesome. Just a couple, we want to go through just some very quick strategies. I know we're running out of time, but one thing is as you look at these waivers and think of them through as a team, we really encourage you to use them judiciously. Really think about what it is. The whole goal here is about putting patients before paperwork, which I love. We all do, I'm sure, but they still need to be reconciled in the end, most likely. And so, CMS's expectation is that this will, when things return to normal, whatever normal may mean in the future, and after that declaration the emergency declaration is over, that we need to go back to our normal routines and the waivers will go away. So if you can, and it looks like the vast majority of you are staying on top of it, but if you become affected by the COVID virus, and within your facilities, things may change. And so just be thinking about that. And so you really want to maybe try to prevent that massive cleanup at the end, especially if you're using the Medicare advance payments, so just be thinking about that and be very careful about how and when you use. Next.
Yeah. And from the survey standpoint, we've just finished talking about the focus surveys. CMS is publishing their findings, and there's been a lot of publicity about those. So familiarize yourself with those findings. Look back in your prior survey history for the 880, 881, 883 citations. They're always in the top 10. So chances are there's at least one citation. But look for the repeat citations, of course, standard survey prep. Look for that G and above scope and severity. Of course, you would know if you have a history of immediate jeopardy as well, that you will definitely need to be prepared for surveyors to pay you a visit. We already talked about the checklist for self-assessment, and most people have done that already. And just making sure that you can have those return demonstrations in hand washing and PPE and get that documented.
Great. And if you haven't already, it's really important to designate a point person for monitoring the CDC and the CMS updates. This can be the administrator, or you can divide it a little bit, administrator, the infection control practitioner, or other key leader in the facility. But it really does take, it took our team, a significant amount of time to go through and stay on top and really interpret those. We're going to keep doing that for you, and we want to make sure, watch out for our blogs that any updates will provide. But it's really important that you keep that, keep in tune with that as well within the facility. If you have some kind of a daily huddle briefing or your stand-ups, consider adding obviously updates on the communicating of those changes, and then do some problem solving with the team at that time. Or if you don't have a daily huddle, that maybe have a dedicated one for this. It also, you can be at your department head level, but also be at the unit and the shift level, which also builds that camaraderie and that team spirit. And key thing here, checking in with the staff needs. Undoubtedly, this is taking an emotional toll on them. I know I'm sitting at home and thinking about how this is impacting me, but I can't even imagine what it must be like for you all and the staff, and knowing, your own internal anxiety about you getting sick or passing it on to a family member, that's very, very stressful. So really making time to focus on your greatest resource, which is your staff, making sure that they get good rest breaks in between, making sure nobody's signing up for too many shifts and getting overly tired, and providing opportunities to laugh and decompress. I think that's so important. Next slide. You know, and lastly, one of the things that we really, really want to talk about is we want to recognize you all and let you know how proud we are to call you our colleagues and how grateful we are for your dedication to the residents, going in day after day, fighting this battle despite your own fears and worries about your families. We truly believe you are all healthcare heroes. And for those of you that have been on social media, you'll notice here, and if Jen, if you can kind of go through the next few slides, we're retweeting the things that you're putting out there. We want to make sure that this message, you know, about the wonderful things that are going on in your facilities and your organizations are highlighted. You know, if there's a silver lining in all of this, it truly is about finally the skilled nursing facilities, nursing homes, long-term care facilities are getting the recognition they so deserve. And so if you know, if you have something, stories that you want to share, you haven't done it yet, or if you want to make sure that we're aware, and so that we can, like I said, retweet or reshare your social media posts, please share those with us. We want to keep this positive industry recognition momentum going. And so you can submit your stories to clientengagement@pointright.com. You know, make sure you have all the right permissions in terms of, you know, if people are in the pictures, but we're happy to do those for you and make sure that, you know, we tell your story. Or if you want to highlight a staff member who has done just an exceptional job during this time, this very difficult time, we'd love to do that and get that out to the world. So again, Jen, back to you.
Yeah, so thank you again for your time. I just want to echo everything Maria has said. We're just in awe of all of you, and we support you, and we're going to do our best to keep you informed and support you as much as we can. Even though we're not in the trenches with you anymore, we're also here to help you at PointRight. So this is my contact information. Feel free to reach out if you have any questions about the presentation. And Maria and I collaborated on these slides, so if I don't know the answer, I'll ask her to answer it.
And vice versa.
Okay, well, thank you so much for your time today. Be well, stay well, and we hope to have you again on our future webinars. Take care.